Health equity impacts health outcomes. Existing disparities contribute to the rising rates of maternal morbidity and mortality. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Petterly, senior writer with AHA. In this Members in Action podcast featuring maternal and child health efforts, we're speaking with Dr. Ken Fawcett, Vice President, and Peggy Vander, Manager of Community Health Programs, both with Spectrum Health Healthier Communities program. We'll dive into the importance of promoting race equity to ensure healthy pregnancies, healthy babies, and better outcomes for the community in general. Dr. Fawcett and Peggy, thank you for joining us today.
Yes, thank you so much for having us.
Yes, thank you.
Let's jump right in. Tell us about the Strong Beginnings program. What inspired the idea? When did it begin? And how did you identify the partners?
So it began quite a while ago, starting going way back to the year 2000, when here in Kent County we were seeing Black infant mortality rate 3 to 4, even 5 times higher than the white rate. And so a group of 12 or 15 of us, representatives from the 3 hospital systems, community clinics, community residents, community-based organizations, came together under the auspices of Healthy Kent to form the Infant Health Action Team. Those of us volunteers working in the maternal child health arena looked at national research, local perinatal periods of risk data, FEMUR data. We conducted town hall meetings, community conversations, focus groups with around 350 community residents, and identified 3 areas that we thought would have the greatest impact on improving birth outcomes for African Americans, and that was reducing unplanned pregnancies, addressing social determinants of health, and dismantling racism. And we called that Strong Beginnings. So we continued doing some work around those maternal child health issues. And then in 2003, the data came out that Grand Rapids, at 22.4 per 1,000 live births, had the highest Black infant mortality rate in Michigan. And that galvanized the community. So the Infant Health Action Team convened all the major players and all together decided to apply for federal Healthy Start funding. And by consensus, every one of those agencies selected Spectrum Health as the fiduciary, as the entity best able to manage a large federal grant. So we selected those partners, one, because they were there from the beginning and were already committed to a common cause, and because each partner brought unique expertise. Kent County Health Department, Cherry Health, FQHC, Mercy Health and Metro Health, and Spectrum Health had the maternal infant health program that we built on. Arbor Circle was our community's mental health provider, and the African American Health Institute worked very closely with the African American community and initially housed Strong Beginnings. And then Michigan State University had expertise in evaluation and research. So those are the agencies that formed and still form the Strong Beginnings partnership. Our initial focus was on African American disparities. And then in 2009, the Hispanic infant mortality rate at 12.7 per 1,000 was almost as high as the Black rate. And the W.K. Kellogg Foundation funded us with funding to replicate the program with the Latino community. So what we do is we build on the maternal infant health program, which offers home visits by nurses and social workers. We added community health workers. Some of them are former program participants. A fatherhood initiative, mental health therapists, community education, breastfeeding support groups, wraparound services for the clients, and serve pregnant women and their families until their children turn 18 months of age. And we have a very, very strong emphasis on promoting racial equity and anti-racism work.
I think a key component actually is the utilization of community health workers, people of and from the community. Mm-hmm. Many times they're historical recipients of our care. They have a cultural sensitivity far in excess that I will ever be able to exhibit that can create almost instantaneous trust and help to navigate these complex situations.
You're exactly right. Yes. We credit our community health workers with the success of our program.
Can you share some of the outcomes, especially specific to addressing disparities and engaging community partners? What's been the impact on patients?
We've had, of course, individual impact on clients' lives, helping them navigate legal systems, regain custody of their children, obtain housing and complete education and employment. But from a data perspective, in terms of addressing disparities in maternal child health, our evaluators, Michigan State University, conducted some pretty intensive, rigorous evaluation studies. So first they looked at the risk level of the families that we serve. Some people were accusing us of cherry picking our clients, and that we had good outcomes because we were working with less challenged families. So they did a 3-year quasi-experimental study showing that the pregnant women in our program compared to pregnant women on Medicaid not in our program, that our clients were much more likely to be homeless and extreme poverty, to have a clinical diagnosis of depression, to be in abusive relationships, have an unwanted pregnancy, et cetera, et cetera. And yet those same women had much higher rates of adequate prenatal care, completing postpartum exams, and all their well-child visits. They also had a 7-year study using vital records data that our clients had statistically significant lower rates of preterm birth and very preterm birth. The rolling infant mortality for our program participants from 2009 to the present is 5.7 per 1,000 live births.
And that's roughly equivalent, actually, to the Caucasian population. And so what's impressive is that there has been near normalization of infant mortality rates on a population that used to actually have infant losses at 5 times that of Caucasians for those women that are enrolled in our program.
And in Kent County as well, the disparity ratio has dropped as well from a high of 5.2 to now about 2.2.
Mm-hmm. And it should be pointed out that that number that we're talking about, that 2.2 number, is really reflective of the broad community as a whole, when in fact we are successful in enrolling only 44% of eligible women. And were we more successful in terms of enrolling all eligible women, I'm sure we could drive that number still lower.
What are some of the lessons you've learned, challenges, and pleasant surprises?
So some of the pleasant surprises were, that infant health action team that I mentioned that was 12, maybe 14, 15 of us. That group has now grown to 85 people, including community residents, program participants, working on 12 different committees related to maternal child health. So there has been a great interest and commitment on the part of the broad community and multiple sectors to engage in this work, to work towards the goals of improving maternal child health. So that has been a really nice thing to see, this growing interest in our program, as well as embracing fatherhood. Fathers, as you know, are often the forgotten piece in the maternal child health equation, and that they really do need to be included. They want to be included. They're begging for programs. They also really are enjoy and appreciative of the support that we provide, and they want more services.
And I think something else that's really important is that we've discovered is the pervasive nature of behavioral health concerns among this population. And by bringing behavioral health into the homes, we can overcome barriers around transportation and stigma. By offering these services in the homes, we can improve these birth outcomes. That's a differentiator and something that I think is really worthy of note.
Yes, exactly. Be very flexible in where and when and how we offer those services. So we have a 90% engagement rate in mental health services, which I think is another great success.
And then one other thing that I think has been fascinating for us is that we have created a funding mechanism regarding a tool that's called a social impact bond or pay for success. And it represents a unique blend between investing and philanthropy. And it represents an alternative to traditional grant funding as we looked to try to create some alternatives to that grant. It's a very rigorous process that involves getting compensated for the actual outcomes that we achieve as opposed to being compensated for activities that we engage in. And we're just starting to actually reach a point where we could actually be receiving these success payments. And while I believe that there were 6 or 7 other SIBs in the country, we were actually the very first in the United States to actually apply a SIB to healthcare, whereas typically it's being utilized as a tool to support things like early childhood education or juvenile justice. But here we can create sustainable funding to actually a program that's really improving birth outcomes and starting kids on the proper launch angle for successful lives. So we're really excited about that.
So I was going to say, looking at challenges, I think probably the greatest challenge that we face is that, as you well know, health and birth outcomes are impacted far more by social and systemic determinants than they are by actual direct patient care, health care, medical care. So factors such as housing and unemployment and poverty and unequal education and justice systems. So being able to make a difference as a small community program on those major factors is a big challenge and rather frustrating. We're making some small steps in some areas of those, but those continue to be the greatest challenges, along with having people being willing to engage in addressing racial equity and working very intentionally on dismantling racism and anti-racism initiatives. I must say Spectrum Health and many of our partners have taken some very intentional steps to do exactly that. So that's really heartening to see, but there are many others that are not quite ready to go on that journey. So that's a remaining challenge. And as you know, infant mortality is such a complex issue with so many causes and no single solution. So it requires individual and community and systemic change, as well as multi-sectoral collaboration.
Where do you see Strong Beginnings 5 years from now? Where do you see it growing or evolving?
Well, as I had mentioned before, one of the limiting factors that we have in terms of us creating even a more profound impact across the community is that we are only able to enroll 44% of eligible women. I think that there's many factors that go into that. I think that millennials that are having children now are less interested in being tied down to a home visiting program. And so how can we leverage technology? How can we create a home visiting program without visiting the home? Can we use virtual connections and telephonic connections to still supply a lighter version of our program so that we can impact more people? And that's something that we're definitely interested in trying to expand. We're in the process of collecting data around our SIB work, or this PFS that we described. In 6 years, we'll actually be completing our cohort analysis, and actually the end game to this is actually standing up a Medicaid waiver so that women across the state, and not simply those that reside in Kent County, can actually benefit from similar programming. And so we really hope that that is something that we can try to create. In addition to that, we're really looking to try to train more facilitators in health equity and social justice, while we target individuals who are within the healthcare field, such as our providers, residents, and students, but also the general community as well, because it's going to take a community to try to solve that. And then, of course, we need to be able to position ourselves and be able to demonstrate outcomes that can allow us to continue to be successful as we seek out additional grant opportunities to spread this work, because it is really, really important that we continue to advocate for those individuals who oftentimes go unseen and unheard.
I also want to give credit to the families that we serve. We always get the credit as the program that's achieving these results, but really it's the women and their partners that are making the changes that they need to make in order to have these outcomes. We just provide the tools. We say, look, here are some tools, here's information, here are referrals, but they're the ones actually doing the work and making the changes. So I just want to make sure that the credit goes to our families and clients for what they achieve for themselves.
I was just going to just make one other comment, and that is that, we're proud to be part of this community collaborative, and sometimes Spectrum Health gets smashed together and the entirety of Strong Beginnings is attributed to Spectrum Health. Now, we are the fiduciary. We end up going to the state capitol for advocacy, but at the end of the day, we're really one electoral vote. And I think what makes this program so unique is the fact that it truly is a community collaborative. People may be wearing different uniforms, but we're all kicking the ball in the same direction. And I tell you, when you surround yourself with like-minded people, even from other organizations, I tell you, it's almost limitless what you can achieve. And I tell you, we're blessed to be in a community where that really has been the norm. And so I'm excited not only about this body of work, but how can we replicate this model to address other conditions as well?
It's very impressive how innovative Spectrum Health has been in improving the health not just of mothers and babies, but entire communities through the Strong Beginnings program. Thank you, Dr. Fawcett and Peggy, for joining us today and sharing more information about this important program. This has been an excellent example of how engaging mothers and families and partnering with community resources improves outcomes for mothers and babies. For more podcasts, additional tools, resources, and education for improving outcomes for mothers and babies, please visit the Maternal and Child Health website at www.aha.org/advocacy/maternal and child health. Thanks for listening.